Good morning, everyone. Thank you for joining us for this learning series webinar, Knockout Opioid Abuse Day. Today's webinar is designated for 1 AMA PRA Category 1 credit and 1 ANCC contact hour and 1 ACPE contact hour, 1 AAPA Category 1 CME credit, and 1 ADA CERP continuing education credit. And for any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has been approved by NJOEMS for 1 EMT elective CEU. A few housekeeping items. PA Planner Dean Barone discloses that he serves on the Speakers Bureau of Ethicon. And our faculty today, Dr. Sharon Walsh, discloses that she serves on advisory boards or in a consulting role for Cerevel Therapeutics, Pocket Naloxone, Bearborn Pharmaceuticals, Opiant Pharmaceuticals, Lundbeck, AstraZeneca, and Canopus. She also has a provisional patent for method of treatment with tradapipant, which I think I pronounced wrong, but those are our disclosures for today. Today's webinar is jointly provided by the Partnership for a Drug for New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I thank them for their continued support and collaboration. And I am so pleased to welcome today's expert speaker, Dr. Walsh. Welcome, Dr. Walsh.
Thank you, Angela. It's a pleasure to be here. Are you ready for me to go ahead and share my screen?
Yes, go ahead.
Okay. Okay, Angela, can you see my first slide?
I can. Everything looks great.
Terrific.
Thank you so much. Yep.
Thank you. And thank you for the invitation to join this group today. I'm really happy to be here and have the opportunity to talk to you about something that we've been working on for the last 4 years called the Healing Community Study. And it's really kind of in the context of this study that we're going to talk today about evidence-based practices aimed at reducing opioid overdose deaths. And I'm going to try my best to apply some of the lessons that we've learned during this experience to the opioid crisis in New Jersey. These are my disclosures, which Angela read out loud. And I should say I won't be talking about anything related to any of that work in the disclosures. So the outline for my talk today is to start by just providing some updated statistics on the current state of the opioid crisis as it continues to change over time. Then I'm going to talk about the Healing Community Study and try to give you, as the audience, a general sense of what the design and the deployment of the intervention is that we used at the community level. And I'll talk about the 3 key elements here that are part of the study design. That will include community engagement and expanding evidence-based practices to prevent opioid overdose deaths. And you may notice that that's actually in a larger font than the first one and the third one. And that's because I'm going to spend a little bit more time focused on that. And then about communications related to reducing stigma around opioid use, people who use drugs, and even the treatments that are used to prevent deaths. And then finally, I'll try to go through some lessons learned and suggestions for addressing opioid overdose deaths. So this slide depicts what we call the 3 deadly waves of the opioid epidemic. And these are really kind of defined by what was the primary opioid of use during that period of the epidemic. And so in the light teal color, the first box on the bottom left really shows the initial rise in opioid overdose deaths that started in 1999 and was really related to the prescription opioid crisis, about which we have all heard a lot. And there's now lots of movies and books detailing all of this. You can see, though, even though that was quite a crisis, how the numbers are dwarfed compared to where we are right now. The second wave of the epidemic really started around 2010. And that was with the introduction of heroin into new markets in the United States. So on the East Coast, there's always been a marketplace for heroin. I lived in Baltimore and worked there for 15 years, and that was the opioid of choice and the thing that was most commonly available. However, in lots of other parts of the country, particularly in the interior, heroin really wasn't particularly available. When I first moved to Kentucky from Baltimore in 2005, I really, when I was enrolling people in studies, I would never see anyone who had used heroin. And if somebody did report that they had, it would almost always be because they had been on the East Coast or in Detroit or someplace else. But what we saw was a change in the marketplace whereby heroin started to kind of infiltrate all small towns across America. And then finally, this third phase that we're in right now, which is the deadliest, is the rise of synthetic opioid overdose deaths. And by synthetic, I mean really illicit fentanyl and fentanyl analogs that are largely coming across the border from Mexico and are particularly deadly because fentanyl is so much more highly potent than the other opioids that have been problematic in the past. So I wanted to just take a look at where New Jersey stood with respect to the rest of the country, and also really try to put it into a framework of what I know best, which is what's happening here in Kentucky as well. And so on this slide, what I've depicted on the left-hand slide, on the left-hand figure, are the total number of all overdose deaths that occurred in the past year. So these are data from 2021 from the CDC, which are the most recently available national data. And you can see that New Jersey had over 3,000 drug overdose deaths. And of those, when you look at the figure on the right-hand side, you can see that 2,600 of those were related to opioids specifically. And so in both cases for Kentucky and New Jersey, you can see that the number of overall overdoses, that the majority of those really are attributable to opioids. And that may be people who are using opioids specifically because that's what they are looking for. But with the changes in the drug market, what we're finding is fentanyl going into the market for cocaine and methamphetamine. And so we're also seeing that people are accidentally overdosing who really are not necessarily opioid users nor seeking opioids, but they're finding that their drug supply is contaminated with fentanyl. Here we're looking at it so that it's corrected for the population. The population of Kentucky is smaller than the population of New Jersey. And so looking at the rate of overdose deaths, you can see that New Jersey's rate is about 32 persons per 100,000. And if you look at the rate for opioid deaths, specifically in the right-hand side, you can see that the rate is about 28.6. Here in Kentucky, our rates are much higher, unfortunately, and currently we're ranked number 4th in the nation of the highest overdose death rates. We've kind of hovered around there over the last several years, you know, in the top 5, which is really not something that that makes you happy or that is, you know, an achievement that you want to brag about. You can see I put the population of the two states at the lower part of the slide just for reference. And you can see that New Jersey's population is a little bit over half, I mean, a little bit over 2 times the number for Kentucky. If you look at the overall rates for the United States shown here, remarkably, and I had to check this number repeatedly, the current rate for New Jersey is actually the same as the average rate in the United States. For all overdose deaths at 32.4 per 100,000. But in the right-hand slide, you can see that the average rate for opioids is 24.7 and New Jersey is slightly higher than that. So these are data actually that are from New Jersey. I just have to say, getting ready to give this presentation, it was really fun because I spent a lot of time thinking about data, the lack of timely data. And I spent a bunch of time poking around on the New Jersey data websites, and you really have access to excellent data. And so that was really wonderful to see. What's shown here, though, are the changes from 2019 to 2022, essentially, for submissions that went into the state police for drugs that were seized. And what is being reported in the figure are fentanyl-related submissions. So once the drugs are seized and then they go for forensic testing, then with the report out on what they're containing. And what you can see is that 98% of suspected heroin submissions during the first quarter of 2023 actually contained fentanyl, compared with only 67% during the first quarter of 2019. So this is important to know. And I think it's also important to know that a lot of times people who are using opioids don't necessarily know what actually is contained in the drugs that they're buying. The latest threat that we're facing is xylazine. And xylazine, also known as tranq or tranq dope, is not an opioid. It is an alpha-2 agonist that's similar to clonidine. It's used as a veterinary sedative. If you know anything about prescribing for opioids in clinical practice, we always recommend against prescribing opioids along with sedatives in combination, because sedatives can exacerbate the respiratory depressant effects of opioids. So they're a dangerous combination. In the prescribing guidelines, there are black box warnings from the FDA about avoiding, co-use of benzodiazepines. So this is concerning, both because of the potentially combined toxicity of the drugs, but also because of some of the effects that xylazine produces separately from that. So xylazine has really been spreading throughout the illicit drug supply. It's not just in the opioid supply, just as fentanyl is kind of infiltrating the illicit supply. Xylazine is doing the same thing. It produces physical dependence also, so it can be hard to manage for people who are coming into treatment and you think that you're treating them for opioid physical dependence, and then their course of treatment or their symptomology isn't really mapping on to what you would expect. That could be because they've been exposed to so much xylazine. And then, of course, the thing that's in the news is that xylazine can produce really severe skin ulcers and wounds that can lead to loss of limbs and things like that. And curiously, these actually occur even in people who are not using xylazine intravenously. So it's not necessarily that these wounds are occurring at the site of injection. They can occur in people who are not injection drug users and still be problematic and really need the attention of medical professionals. So these are updated data on xylazine and how it's spreading through the drug market. In the newspapers throughout the country, really the focus was on Philadelphia and specifically North Philadelphia for quite a while when people started talking about xylazine. And in 2021, more than 90% of the illicit drug samples that had been tested were found to actually contain xylazine. So this is really, really prevalent. And so, in treatment programs and things like that, you should kind of anticipate that people are being exposed to this. The figure on the left-hand side was something that I took from the Office of Drug Monitoring and Analysis from the New Jersey State Police. And this is related to testing of xylazine that were found in glassine bags that were seized. And what's stated in the yellow box there is that more glassine bags containing xylazine were analyzed in 2021 compared to the previous 2 years combined. I'm not exactly sure what's happening in the 2022 data where they've declined, but I think maybe a little bit more data in 2023 will help to inform what that trend looks like. In the right-hand side, this is actually the number of deaths that have been attributed to xylazine since 2018. And you can see that there is a pretty steep rise in this. And this is all the more concerning because xylazine is not routinely tested for in forensic testing in decedents. And so that's something that we really need to continue to work on, is to be very proactive and thoughtful about monitoring what's changing in the drug supply and ensuring that we're actually testing in clinical settings for those newly emerging threats. And that would include in autopsy and death investigations. All right, so I'm going to shift a little bit about the healing community study itself. And what it was and kind of why we needed it. So the opioid overdose crisis, as you could tell from that first slide that I showed, continues to worsen despite substantial efforts to mitigate it, with a loss of life of over 100,000 people in 2021 alone. And unfortunately, part of the problem is just our inability to really get interventions to the people that need them. So we're very fortunate in the field of the opioid use disorder compared to, for example, methamphetamine. We have efficacious interventions that can address opioid use disorder, but they really have inadequate uptake and delivery to all kinds of barriers that include structural barriers, disjointed care systems. I'm sure many of the people that in the audience today are working in these systems, and you know that how they're disconnected from other healthcare systems, and of course, stigma and discrimination. And so NIH started really thinking about this. Why is it that we have effective interventions, but the crisis is only worsening? And so they decided that it would be worthwhile doing a large-scale community intervention that was aimed really at trying to expand evidence-based practices and reach the individuals who need them the most because they're at risk of overdose death. And so this was a standard NIH type grant, very, very long. So I shouldn't say standard. It was, I think our grant application was over 500 pages. It was a lot of work. And so academic centers around the country were able to apply for this grant. And ultimately 4 sites were chosen to be funded. And these included Massachusetts, New York, Ohio, and Kentucky. And within the study, we had 67 total communities across the 4 states that were randomized to receive the intervention. 30 of those communities were rural and 37 were urban, representing a total population of over 10 million people. So this graphic describes the timeline of the project so that I can kind of give you an idea of where we've been and where we are right now. So once we were notified that we were going to be funded, the National Institute on Drug Abuse decided that they actually wanted us not to do our own studies that we had proposed, but to come together with a common protocol. So we spent some time initially working on developing a common protocol that could be deployed across the 4 states, but would have enough flexibility to be customizable for each individual community. We started the intervention in January of 2020 in the first set of communities. So there, we call those wave 1. Those were the ones that were randomized to start first, while the second set of communities, or wave 2, were on what we call the waitlist control. So this is how we do a controlled trial, where we have one receiving the intervention and the other communities are kind of doing their usual thing. We didn't stop them from doing anything that they already had underway, but they weren't receiving the intervention. And then we would compare overdose deaths and a lot of other outcomes at the end of this period. And the comparison period was designated as July of 2021 for a 12-month period. We actually had to change the timeline twice. You can see that when we started in January 2020, we had no idea that we were about to confront an unprecedented global pandemic that was going to shut down virtually the country and almost all the partner agencies that we would want to work with in healthcare and criminal justice. And so we really had to quickly pivot. Where we are right now is here, where we're doing the analyses for that intervention period, but we are also still delivering the intervention to our wave 2 or waitlist control communities that waited all that time to receive the intervention. So we're getting close to finishing that in wave 2, and we're also getting close to publishing some of the top line papers from the study. So the actual intervention had 3 components. The first was community engagement, and this was really where we worked with community coalitions in each community that were provided access to data that could help them understand what was happening on the ground in their community, do a landscape analysis so they could see kind of what they did and didn't have and figure out what the gaps were so that we could fill those with the resources from the project. And the community coalition would actually help to guide the process of the intervention throughout so that we had local champions on the ground who were fully informed and participating. The second part of it is what we call the ORCA. And essentially what this is, the scientists across the 4 states came together and came up with a compendium or listing of all the potential evidence-based practices that are known to have an impact on overdose death. And so once the community coalition was engaged and informed, they would make selections around what types of evidence-based practices we would be deploying and where in their communities and kind of on what scale. And then the third component is the communication campaign. So this was really, we had a series of public health campaigns run throughout the intervention. And the goal of those campaigns was really to alert people to the fact that this work was underway, to reduce stigma, to get local champions to appear in some of the communication campaign materials, to talk about their experiences, getting it, into recovery through the use of methadone, or showing people that, naloxone is not enabling, things like that. And so really trying to drive demand for the evidence-based practices and reduce stigma. So what's needed for community engagement and planning? And I think that, this is kind of where I first started thinking about, like, how would you take this study and then make recommendations to other communities about what they could do? So I think a lot of community planning relies on coalitions, but some places have existing coalitions that are focused on this, others don't. And in a lot of cases, community engagement or planning can really more commonly fall to policymakers and local authorities like fiscal courts or detention centers, public health departments. And not all of them are always really informed about what is evidence-based versus non-evidence-based practices. And so I think kind of activating and making certain that we're able to provide technical assistance and information and have kind of a group of people that are really informed about what is the evidence for certain interventions available to help guide these types of discussions is really critically important. I think it's also really important that communities and decision makers have access to current data and understand local gaps in services. And that's not always readily available. So it was really, really striking to me when the COVID-19 pandemic started, how we could know on any given day exactly how many people were in ICU or were infected across the entire country, but we don't have something similar that's timely for opioid use disorder and the opioid overdose crisis, despite the fact that this is also an epidemic that has been killing a lot of people. And so there's a real gap in our ability to have timely data, and it's something that I think we need to focus on. For the Healing Community Study, we employed 52 different administrative data sources to understand the landscape. These included things like Medicaid and death records, hospital claims, emergency medical services, prescription drug monitoring programs, syndromic surveillance, and a lot of others. To actually stand those up and get access to them is really quite a bit of work and not something necessarily that communities are able to do. So I think that at the state level, it's really important to leverage the data that are available. And in New Jersey, you really have some timely data and really very lovely reports that are available for planning. Now, to the extent that they kind of, focus down from the state level to the county level, for local planning, I think that that's something that needs to be considered. So this is just an example of thinking about timely data. So these were different data sources that we had available to us to allow us to monitor opioid overdose events in the community. And I'm going to start with the overdose deaths, and that's in the purple line at the very bottom. And those data in Kentucky, we have about a 4-month lag, but there are states that have about a year lag in their reporting out for overdose deaths from the medical examiner's office. And clearly you can't be responsive to something if you're only finding out about it a year later. And so that's something, that really needs to improve. Then we had 3 other types of data that we looked at: emergency department data for admissions related to overdose events, syndromic surveillance, so the emergency department data has about a 90-day post lag, and then syndromic surveillance has about a 2-day lag, and then emergency medical services, which is really like ambulance and fire runs for overdose, which is very up to date, within a couple of days. And so what you can see here depicted, despite the fact that we're talking about very, very different lag times, you see a very similar pattern of findings. And so the idea that you could use something that's most timely when the patterns are pretty comparable is probably like the recommendation that we should be thinking about when we're comparing data sources. So, we're all now in this position where opioid settlement funds are coming through to our states and to our local governments to spend in order to help reduce the burden of opioid use, hopefully to address the overdose crisis, and to reach the people in our communities that are most at need. New Jersey will receive $641 million in funds, which is a huge boon, and hopefully will be invested wisely. So it's really critically important that a data-driven approach be employed at the state and local level to ensure that the funds are used to improve the timeliness of data to inform solutions, are directed at supporting evidence-based practices and not directed at supporting things for which there is no evidence. And finally, to reach the people who are most in need. And those people, I would say, are those who currently are suffering with opiate use disorder, their families, and their survivors in many cases. What we see in some states is that states are deciding to use these funds to build new roads, which is really probably not going to save anyone's life that has opioid use disorder. And so I think that it's really important that our voices be heard when these decisions are being made. So I'm going to come back to I talked a little bit about community engagement, but I really want to focus on what are the evidence-based practices and what can be done to expand those. So in the Healing Community Study, we identified 3 what we call buckets of evidence-based practices. And within each of these buckets or the things that are enumerated here, there's actually a lot of different ways and strategies that can be used to go about doing these things. So the first is opioid overdose prevention, education, and naloxone distribution in high-risk populations. The second is effective delivery of medication for opioid use disorder for maintenance, including agonist and partial agonist medications specifically, and including outreach and delivery to high-risk populations. And that would include those people who are incarcerated, for instance, or who are detained and about to be released, which we know is one of the times that's the highest risk for overdose death. And then finally, focusing on safer opioid prescribing and dispensing. This is something that we've really been working on now for, well over a decade. And most states are making really good progress in this area. So in the study, as I said, the communities were allowed to choose what kinds of strategies they wanted to implement. And this is just for the Wave 1 counties. So this is just for the people that started the intervention first. And you can see the difference across Kentucky, Massachusetts, New York, and Ohio. The colors for each of these reflects OE&D, which is overdose education and naloxone distribution, MOUD, which is medications for opioid use disorder, and then the safer prescribing. So we had lots of experience trying to implement different types of interventions in a variety of settings that included behavioral health, public health, health care settings, criminal justice, and harm reduction services. So, and here you can see the breakdown across those different agencies. And I think that I'm showing this slide mostly because I think that we need to have a very global perspective or broad perspective about how to intervene. Substance use is an incredibly complicated situation. It's not just a medical condition. It is a medical condition for the individual, but we know that there's also all kinds of sociological issues. There's social determinants of health. There's other psychiatric comorbid disorders that play a role in this. And of course, criminal justice, because it's illegal to use drugs. And so many people who are at high risk end up in the criminal justice system where they may or may not get offered any kind of treatment. So the idea that we really need to have a multi-pronged approach and be thinking more holistically about all of the agencies in our communities that are touching individuals who are at risk, and how we can help them to stand up interventions that will actually get people into the care that they need. So for overdose education and naloxone distribution, there's different approaches that can be used that include active outreach for OE&D, for high-risk individuals and their social networks, active outreach at high-risk venues like criminal justice settings, syringe service programs, emergency departments, leave behind programs, for instance, with quick response teams. You can do referral, you can do it by mail, you can do it by self-request. And the capacity for first responder administration. So when we first started the study in Kentucky, there were first responder EMS programs that did not carry naloxone at all. which was just stunning to me. And so trying to get those agencies to recognize the value and importance of that was, really kind of about changing hearts and minds. We had in our first wave of communities, a public health department in a more urban area where people are pretty well informed, who were convinced that it was actually illegal for them to distribute naloxone. And so in that case, we really needed to leverage our partnership with our state officials to help come and educate that public health department and assure them that, in fact, it was not illegal for them to do that. And we were able to stand up a nice program. So for each of these evidence-based practice approaches, I'm going to give you just a couple of examples of things that we did in the study to give you a flavor for that. So in Kentucky, for overdose education and naloxone distribution, what we did was we set up something we call a hub with many spokes. And the hub and spoke model has been used to expand access to care with buprenorphine and methadone as well. And it really is where you kind of have a central place. It might be an academic center where you have plenty of experts that are then going to help as the hub, the spokes that are community practices that might not have as much experience, or maybe in the case of treatment for opiate use disorder, they don't have the sufficient resources for dealing with really complicated patients or comorbid psychiatric disorders, but they have some place centrally to come to. So we set up a program like that where we were the hub, and then we partnered with about 170 different agencies across the different sectors, who then were the ones that were actually doing the education and distribution, and we were providing the naloxone to them. And so we also then deployed people who were called prevention specialists, most of whom had lived experience, directly into communities to actually do training and distribution at any place that would let us, outside of a storefront, at festivals, gas stations. And we had a commitment to equitable reach. And so you can see that in wave one alone, we distributed over 41,000 units. Each unit is 2 doses of naloxone. And that the group that we reached was about half female, about 11, close to 12% racial ethnic minority. And in Kentucky, our persons of color represent only about 8% of our total population. And then 36% of them were under 35, which we know is, a group that's highly at risk. In New York, one of the things that they did was they used geospatial mapping that examined where overdoses were occurring based on local data, EMS runs, 9/11 overdose calls, and overdose maps to determine where to put naloxone boxes. Naloxone boxes also is something that, has policy around it at the state level. And so if that's something that's not currently available in New Jersey, there's plenty of precedent where other states have gotten that type of legislation approved. But essentially, it's like an IED. It's like having emergency available naloxone someplace. And in New York, they targeted motels that were in neighborhoods with high overdose rates. We did something similar here and worked with colleges and universities. And then identified lots of other places that were at risk. So that's a way to kind of have a sustaining impact where you're expanding availability in the community rather than just giving a unit to an individual person. And then, of course, we had a lot of campaigns that were running at the same time to try to encourage the use and reduce some of the stigma around naloxone and some of the misunderstandings around naloxone policy. So I want to touch on the point around harm reduction programs, because I think that they are really a critical key touch point for people who are at the highest risk. And what we know from the evidence is that access to harm reduction syringe service programs can really decrease transmission of infectious disease, can promote safe drug use, including access to naloxone and drug testing strips, pardon me, including those for fentanyl and xylazine, and really critically provide an important linkage to healthcare. So lots of people who are using drugs or those who've been using chronically often are not touching the healthcare system, and in many instances don't want to touch the healthcare system because their past experiences with healthcare have been negative and where they felt like they were really stigmatized. And so this is usually a safe place, often that has people with healthcare licensing who can, really develop relationships with individuals who are coming in. And if they're not necessarily ready for treatment, on day 20, when you have that relationship and now it's day 60, they may be reconsidering. And so they can serve as a really important place to link people to substance use treatment. In Kentucky, we're really fortunate. Despite the fact that we're a red state and pretty conservative, we have 82 syringe exchange programs that are spread across 63 counties. And I'm just going to say that in large part, the reason that I think that this has occurred is because we have someone who's a well-respected champion who actually comes from a criminal justice background that works for the state and advocated a long time ago for the benefit of syringe service programs and helped to lead the charge to get legislation approved for them. The way that the decision is made, it's made at the local level. So, it's legal at the state level, but then at the local level, people have to get together, including the public health department and the county judge executive, to make a decision as to whether or not that community wants to have a syringe service program. And we actually have more syringe service programs than any other state in the country. For New Jersey, and you have twice as many people as we do, harm reduction centers, as they're called there, were originally legalized in New Jersey 16 years ago. And there's currently 7 harm reduction centers, as best as I could tell from scouring the internet, mostly in these large cities. And I know that last year, the governor signed a new law to decriminalize use and possession of syringes and fentanyl test strips. But it's not clear to me whether or not communities are working to expand the reach of harm reduction centers and to increase availability to other places in the state. I could find old information where there were 7 centers, and I could find new information where there were 7 centers. So it's not clear to me whether or not that's growing, but I'd be happy to talk about that with people who are in the know during the discussion period. The other area, of course, is medications for opioid use disorder. There's 3 FDA-approved medications. Methadone, which has been around since the 1970s, is only delivered in highly regulated federal opioid treatment programs. Daily dosing is often required in person, which makes it very hard for patients to remain compliant. Imagine if you had to go someplace every day to take your thyroid medication or your cholesterol medication. Buprenorphine is delivered in office-based care models by physicians and mid-level providers. New Jersey actually has a very large number of people who are licensed to provide buprenorphine, so it seems like you've got fairly good penetration there. Naltrexone is the other medication that's approved. It's not a controlled substance, but it still is by prescription only, and it's available in an oral or monthly injectable formulation. So what we know is that less than 10% of the people who have opiate use disorder actually have received an FDA-approved medication. So imagine that for any other condition that you had treatments available that were highly effective, and less than 10% of the people who needed them were actually able to obtain them. And this illustrates the finding that methadone and buprenorphine are highly effective at actually decreasing opioid overdose death. And so you can see the risk of death in the red bar is people who have opiate use disorder but are not receiving treatment. But once they receive medications for opiate use disorder, specifically methadone and buprenorphine, that risk is reduced considerably so that their death rate is much more comparable to that in the general population of people who are not experiencing opiate use disorder. So we know from a variety of studies now that methadone and buprenorphine can decrease the risk of death by 50 to 82%. And so again, shocking, right? That we have, if you had a drug for any other medical condition that could cut the risk by at least half that someone would die from that condition, but you only gave it to 10% of the people, then I think everybody would be suing for malpractice. But that's not what happens in this case because there's just so much stigma around these medications. I think it's important also to recognize what the difference is between buprenorphine and methadone and naltrexone. Naltrexone is really favored by people that are in the criminal justice system because it does not produce psychoactive effects in contrast to buprenorphine and methadone. And so sometimes we see that even judges are determining what medication should be prescribed for people, which is ridiculous because they don't have a medical license. But when we actually dig down and look at the data, and these data are from Kentucky, and we're showing retention in care of at least 6 months, you can see that methadone actually, despite the fact that it's so burdensome to actually stay in treatment, it has the highest rate of retention. At over 85% of the patients are staying in for 6 months or more. Buprenorphine has 67%, but naltrexone is only at 12%. So the majority of people that get their first injection of naltrexone don't come back to get a second one, and that means that they're not protected from overdose. So we had a lot of different strategies that were used for expanding access to medications, improving linkage to care, in increasing retention in medications, in treatment with medications for opioid use disorder, including addressing social determinants of health. And so this is just a really clever program that Massachusetts deployed, where there's like a known high-risk population that is in the fishing industry in Gloucester. And so they actually brought a provider and opened an office on the pier. So really about bringing treatment to where the people are that are at risk. And then Ohio really worked very closely with their criminal justice system to work on getting people into care with medications that were in jail awaiting trial or had been released under supervision. And they would start people before release to initiate medications so that they would be monitored when they were released under probation to ensure compliance with their treatment programs. And then, of course, we had accompanying campaigns to help reduce stigma and drive demand for these medications. So it's really important that we think about reducing barriers to care because, you know, when sometimes I hear people say, well, these treatments don't work, people don't stay in the treatment. The barriers that people face to staying in treatment are just so daunting that it is remarkable that anybody stays in treatment, in my opinion. So sometimes something as simple as a lack of an official ID that could cost $10, it can be a barrier to care, office copays, pharmacy copays, having adequate childcare, anything that increases the risk for people being homeless, houseless, or unhoused, including past unpaid utility bills or criminal charges, recovery housing that prohibits the use of FDA-approved medications, which I think is actually an ADA violation. And then transportation is one of the hugest, you know, so if you think about needing to get to care every day in a methadone treatment program and you don't have a reliable car, you are in trouble. So one of the things that we did here in Kentucky was we recognized that in a very rural population in Madison County, there were people that were enrolled in the closest methadone treatment program, but it was really quite far away. And so we worked with our partners called Voices of Hope to develop a transportation program during wave one. And there were over 2,600 rides that were provided to 151 unique individuals. And this equated to, because of the distance, 5 trips around the world in that year during the intervention period. But the opioid treatment program commented on the fact that they had people who were being retained in care longer and who were being more successful and advancing through the program. New York provided a lot of temporary housing vouchers with care packages. So this whole idea really of kind of linking all the social services, everybody has a role here. And really, you know, if you're doing any kind of casework, really knowing what else is available in your community to help assist individuals is critical. Improving prescription opioid safety, you know, all of this is really largely around education in the healthcare system. Prescribing in New Jersey is shown here. This is opioid prescription rates per 100 residents, and you can see that they've really gone down over the years. And so I think that that you're doing a good job. But then, like very similar in Kentucky, when you look a little more closely, what you see is that there are particular areas that are problematic. So in the map here, the areas that are in the darker colors are the ones that have pretty high rates. And so like if you just look at the difference between Hudson, which is 17 prescriptions per 100 versus Atlantic, which is 46, that's a pretty significant difference between those two. And so that suggests that maybe there's some work to be done still. And then we did a lot of outreach in Kentucky to dentists and primary care providers and pharmacists, trying to make certain that everybody was really aware of what the CDC guidelines and what strategies could be used to improve safe prescribing. And that included offering disposal units. And so I don't know what the situation is in New Jersey. But I do know that in a lot of places, when we started the study, that the only place that people could dispose medications was at the police department, and lots of people don't want to go there. And so we were able to offer pharmacies installation of these DEA compliant med safe disposal kiosks, and it was highly effective. So I'm going to close here so that we have time for discussion. I think kind of overall, my messaging is that really a multi-pronged approach is needed to increase access to naloxone. It really works. It works against fentanyl, despite what you may hear sometimes. And even in the case where xylazine is on board, if it's on board with an opioid, naloxone still can effectively reduce the effects of naloxone, or reduce the effects of the opioid. And so it really should still be deployed. It's now available just through a decision by the FDA this past year over the counter, rather than by prescription, which one might think that it actually would make it more easy to access, but I'm not 100% certain that that's how it's going to turn out, because that means people need to go to the store and pay for it. So really still the provision through public health of free naloxone, I think, is critically important to sustain. New Jersey has interesting results on their websites where they report naloxone administrations by the quarter. I'm not 100% sure how those are actually measured or documented. So I'd be curious to hear from somebody about that. That's something that we're missing here. I think it's really important to improve access to medications for opioid use disorder through expansion, reducing restrictive policies, and enhancing patient supports by barrier reduction. Reducing stigma around substance use disorder, people who use drugs, and even their providers. We all have a role in this as people in the field. Language matters. We need to be careful about how we talk about individual people that are struggling with substance use disorders. And remember that it's a medical condition that can be treated. We need to continue to provide medical education around substance use disorders and safer prescribing. It's always surprising to me when I'm talking to rooms of doctors and I say, how many patients of yours do you think have substance use disorders? And sometimes they say none. And of course, that just means that they're not actually asking the right questions. And then finally, we really need to continue to work with policymakers to change laws or regulations or practice guidelines that are in the way of providing harm reduction services and appropriate access to care. And then I'll close just with providing some hope, because this has really been a bipartisan issue that people on both sides of the aisle have been really supportive of trying to address, although we still have quite a bit of work to do. This year, or just last year, the federal government passed the MATE and MAT Acts that eliminated the specific prescriber requirement for the DEA X license for prescribing buprenorphine. The COVID-19, a silver lining was that we ended up having telehealth waivers for the first time to allow people to enter treatment for substance use disorders without having an in-person visit. We were able to do telehealth visits with patients that were enrolled in care, and these have been extended because they were viewed as successful and not actually contributing to any kind of, or leading to any harms. We have a lot of opioid abatement money that's coming to the states, and the hope would be that we can direct these at expanding evidence-based care. And as I said, we have bipartisan support for addressing the epidemic, and I hope that that continues, because we don't have bipartisan support for many other things at this point in time. All right, with that, I'm going to close and acknowledge all of my colleagues across the consortium and the different sites and our government partners. And then these are the disclosures actually about the grant. So thank you very much. And I'm happy to take any questions you may have.
Thanks so much, Dr. Walsh. That was a really great presentation, and just comparing and being able to see where New Jersey stands and where other people in the country are. So appreciate that. And I'll go to some of those specifics on that. But I just wanted to pick up on the naloxone and harm reduction conversation that you kind of were ending with. We had a question from a pharmacist that came in who said, as a pharmacist, I see an increased use of naloxone, but I just see it as a panacea. Yes, it saves lives, but I think it encourages the problem. So can you speak to that? Because I know you were touching on medically assisted treatment and the need for naloxone. Can you address that?
Sure. So, that's something that I've commonly heard, is that it is somehow enabling. And I think that that is just faulty thinking, honestly, because people who have physical dependence on opioids, most people once they reach the point where they have a severe opiate use disorder, they're not particularly happy about it. And it's not like they really want to continue using drugs, but because of the physical dependence and the withdrawal that occurs, that is so anxiety provoking and so incredibly uncomfortable, people are really compelled to continue to use. Most people who overdose, it's accidental, it's not intentional. And so the idea that somebody would, get something that was particularly potent and they think that they're using the same thing that they used yesterday, but it actually isn't, and then it kills them. I mean, and we see this now with the fentanyl being pressed into pills and things that look like Adderall. We see college students who actually are not using drugs, or they're not, it's not the kind of their common practice, and then they take one thing and then it kills them. I mean, this is, we're just in such a crazy crisis, and we have an antidote, right? We have naloxone, which is safe for everybody to use. And what it really does is it provides an opportunity for someone to live another day. And if it was your daughter or your son or your parent, I mean, wouldn't you want that person to have another chance? So, and if they don't have that chance, they're never going to go into treatment and recovery, right? So what we really want is to try to keep everybody alive until they are at the place where they can access care. But, I think that kind of thinking actually arises from stigmatizing attitudes that somehow, people are doing this to themselves. So what if they die? I mean, I've heard people say things like that, and it's just heartbreaking for me, honestly, because these are not them, they're us. These are people that are in our community. These are our children. These are our parents. These are our siblings. We really need to care about each other.
Thanks for addressing that. I appreciate it. We have another question. I just want to mention that the poll has launched. So if everyone could just give us our feedback on today's webinar, I'd appreciate it. We have a question, and you talked about the role of prescribers, and here in New Jersey, we introduced legislation that requires that the time an opioid is prescribed, that people learn about alternatives. They're told about the potential for dependency and addiction, and 18 states around the country have enacted that legislation in following New Jersey's role. Kentucky is not one of them, but there have been some states that have that. And so we know the role of prescriber and prescriber education, and there's credits available for today as well, continuing medical education. So we have a question from a nurse who says, I'm an acute care critical nurse, and I'd like to see, what is a nurse's role in preventing or in early identification or in early intervention? Can you speak to that?
Sure. And so I think the question is really, what's the nurse's role with respect to identifying either risk or like potentially problematic behaviors, right? So I think that we all have a role, and nurses are so critically important. Nurses spend so much more time with patients than doctors do. And nurses nurses talk to the patients more than doctors do. Doctors are on these really tight schedules. They have to get in and get out of the appointment. Nurses are the ones that are coming in and trying to figure out, at the start, how's someone doing, what's happening. And so I think that nurses play a critical role in all aspects of this, and also in identifying, if you're in a hospital setting, are there better practices that you have that your institution hasn't put into place yet? Are there things that you can easily incorporate into your EHR, for example, to flag things that no one has considered before? So I think, I think nursing voices are critically important. And I think that they are really one of the groups that's on the front line that spends more time with patients, both in kind of acute care settings, but also in public health settings.
No, thank you for that. So just, I know we're kind of running out of time. I did want to mention that New Jersey is expanding their harm reduction centers, doubling the amount that we currently have. So that movement is going on. And we also have over 200 80 disposal locations. We put a lot of effort into getting that information out. But what other strategies, I know you spoke about, what other strategies for those who are in public health, or who are in the community? You talked about the role of community coalitions, and we have many people who are on, aside from our prescribers and medical practitioners, who want to prioritize or have their voice heard as the opioid settlement money is starting to be distributed. Can you talk about some top priorities that people can advocate for? I know you mentioned a few things, but some
Yeah.
other.
Sure. I mean, I think that people that are living in the communities really kind of understand, if they're paying attention to the problem and they're concerned, they understand what is and isn't available in the community, and what is and isn't actually helping the situation. And so I think that trying to identify what those areas are for improvement, and then trying to advocate for that, and getting access to the people that have authority over making those funding decisions is critically important. I'll tell you just as an example, and you told me not to look at the chat, but I can't help but looking at the chat, that one of the things that was most depressing to me was that, as I said, we reached out and worked with all kinds of different agencies. And what we found was that the ones that we had the least traction with were healthcare and hospitals. And so I see chats in here that, people that have substance use problems are coming in the emergency departments, and they're taking up space or taking up resources. But I would ask what that emergency department is doing about providing treatment, because emergency departments can actually start people on buprenorphine and get them under their withdrawal and their dependence under control long enough for them to give them an actual referral, not a piece of paper, but an actual referral linking to care. And we just don't see many emergency departments doing that. And I know that emergency departments are overcrowded and they've got people living in the hallways and all those types of things. But I think looking kind of at the long-term benefit is that if you can kind of reduce that flow by actually getting people into care, you'll actually see that things improve in those settings. And so changing hearts and minds, it was discouraging for me, because I think people that go into healthcare do it because they care about people and they want to take care of them. But it was challenging to affect change in some of those settings. And a lot of it came from, I think, kind of stigmatizing attitudes.
No, I think I'll leave you, I think on that note, I think unfortunately, right, I think that we're still facing so much stigma, and anything that any of us can do to help eliminate that stigma. I know you talked about some campaigns, but just in language choice, and this webinar series, we've addressed those things. But I appreciate also, right, how people are dealing with this and have been dealing with this issue on the front lines for many years, and frustration that people may be feeling. But I think your point earlier about saving a life is the ultimate goal of all of the work that we're doing. So we have about 1 minute left. If there's any last comment you'd like to leave us with, but
well, I remain hopeful. I've been in this field for a really long time, and I'm seeing kind of the devastation of this newest scourge of fentanyl and now xylazine, and it is very disheartening. And I don't want people that are in the audience to think that I am judging them either. It is hard. It is hard work, and burnout in this field is a very, very real thing. But I think that there really is hope. And I think that this is also an area where I hear every day that, it's a place you get somebody into care and they are transformed. You just see how they can change in a period of a month of stabilization and care. And so I think that we just need to continue to fight the good fight and try to make sure that we're giving access to care the way that we would for any other medical disorder in this country.
all right. Well, thank you so much. Again, your presentation was just outstanding. And so we really appreciate you taking the time to join us today. We're so glad to have you. Thank you for all of our attendees who are on with us today and for your feedback and questions. We appreciate it. Information is on the screen on about how to register to get your continuing education credits. And also our last webinar of the year will be on Thursday, December 7th. And we hope that all of you can join us. So thanks everyone. Have a great day and be well.
All right. Thank you, Angela. Thank you,
Thank
everybody.
you.